Hello, my name is Joseph Castellano. I'm a community pharmacist, educator, and advocate for patient care. What started out as ACHOO's dedication to adherence, compliance, and health outcomes revealed a much larger problem in healthcare communication. Pharmacogenomic information is often fragmented across systems and buried inside PDFs that providers cannot easily optimize at the point of care. At the same time, diabetes and obesity care, along with GLP-1 therapies, are transforming medicine. I wanted to help solve both problems. Pharmacogenomics should support better prescribing decisions, but interoperability remains a major barrier. Genetic information may exist, yet it's often not computable, actionable, or integrated in the clinical workflow. Providers are left navigating disconnected systems, static PDF reports, and fragmented data. Meanwhile, GLP-1 therapies are expensive, variable response, and difficult to authorize through insurance. This is interoperability madness. My interest sparked after a 2026 Nature study of a GWAS study of patients identified with pharmacogenomic signals associated with GLP-1 response and gastrointestinal side effects. A GLP1R missense variant was associated with greater weight loss. And also variants in GLP1R and GIPR were also linked to nausea and vomiting. This is not clinical guidance yet. These findings still need prospective validations and clinical implementation studies, but they are forward thinking and they point towards the same future as interoperability. Precision medicine clinicians can actually use. Today, without pharmacogenetics, a patient may start tirzepatide, they may get really sick from it, and they can stop therapy and not get the care that they deserve. However, with ACHOO PGx, GIPR risk is detected before prescribing. Semaglutide can be considered earlier with the rationale that the clinician can use. This is the goal, not simply reacting to side effects, but by preventing them. ACHOO PGx is an AI-powered pharmacogenomic clinical decision support system designed to bridge these interoperability gaps. Using FHIR-based patient data, MCP decision tools, and A2A multi-agent orchestration, the platform transforms fragmented genetic information into actionable prescribing recommendations. Here is what it looks like in practice when agents assemble. The patient's FHIR record enters a system with long-coded demographics, medications, pharmacogenomics, and clinical context. Superhero MCP empowers the CPAC guidelines, GLP1 PGx model, and drug interaction logic. The gene interpreter agent detects GIPR variants and flags increased vomiting risk with tirzepatide. The medication optimization agent evaluates tolerability, clinical context, and treatment goals. The output, semaglutide can be considered earlier with a clinical rationale that the provider can use. This is the difference between static data and living clinical guidance. Not a black box, a reasoning chain the clinician can trust. This is not just about AI. It's about making obesity care and diabetes care more personal, more explainable, and more equitable. Better therapy selections may improve adherence, reduce side effects, lower unnecessary costs, and strengthen prior authorization evidence. For patients, this means fewer abandoned therapies. Provider means clearer clinical rationale. And for pharmacists, it means a larger role in precision medicine. Pharmacists are uniquely positioned to lead this transformation because they are ready to translate complex medication information into actionable patient care every single day. Now we're going to go through an example of how this works in prompt opinion. Here inside prompt opinion, I published the PGx Clinical Orchestrator as an A2A agent. It uses MCP decision tools, FHIR-style patient context, and pharmacogenomic reasoning to support explainable medication optimization. Are y'all ready? In this demo, I give the agent patient-specific context for obesity and type 2 diabetes, comparing semaglutide versus tirzepatide. In this case, the patient has GLP1R and GIPR pharmacogenomic variants. The agent generates a structured PGx clinical decision support, including the genetic profile, drug gene interpretation, therapeutic recommendations, ranked alternative, confidence level, and a clinical disclaimer. The key point is this: it's not a black box. The agent shows this reasoning chain. It identifies the GRPR associated vomiting concerned with tirzepatide, and also considers semaglutide as an earlier option. And clearly states that GLP1 pharmacogenomic is emerging and not a routine clinical guidance. But this is where we start. We start here, then we keep building, and we keep improving. My vision is simple: transform pharmacogenomic information from static data into living clinical guidance. The right drug, the right patient, the right time, because precision medicine only works when communication works. Thank you for listening. Bye.